All right, hello and welcome to the ENVISION webinar on the IEC and Social Mobilization Toolkit, which will include an overview and practical experiences from both Ethiopia and Uganda. My name is Kaylee Robinson. I'm a capacity building specialist for the ENVISION project at RTI International, and I'll be facilitating the webinar today. On behalf of ENVISION, thank you all for joining us. We hope you'll find the webinar useful in your work to control and eliminate NTDs. Let me introduce our speakers and the agenda for today. First, Geordie Woods, NTD Technical Advisor for Sightsavers, will provide background on the toolkit. Then our panelists joining from Ethiopia today will share their experience with the toolkit. And that'll be done by Baruch Kebede Bayen, the Deputy Chief of Party from ENVISION Ethiopia, Baruch Kebede, the NTD Program Coordinator at the Federal Ministry of Health of Ethiopia, Leah Wohlgemuth, the Regional NTD Technical Advisor from Sightsavers, and Scott McPherson, NTD Senior Manager at RTI International. And after that, Benjamin Benagwa, the Resident Program Advisor for RTI International Uganda, will share his experience using the toolkit there. For those of you who are new to webinars, if you look up in the top right of your screen, you should see the GoToWebinar toolbar, which provides some guidance. You should be hearing the audio through your computer, and if that's not working well, you can call in through the phone by clicking on Phone Call in the audio section. At any time during the webinar, if you have questions for any of our presenters, please type them into the question box, and we'll do our best to address them in the Q&A time that we've saved for the end of the webinar. There's also a copy of the toolkit available in the bar on the right side of your screen if you look under Handouts. We'll also be emailing everyone after this webinar with a copy of the toolkit, this presentation, and a recording of the webinar. And at the end of the webinar, please take a couple minutes to complete a short evaluation. Your feedback is really important to us so that we can make sure we're addressing the topics that are useful to you. And finally, if you find this webinar beneficial, you can find slides and recordings of our previous webinars on our website. So I'll give a very brief overview of the ENVISION project before we move on with our speakers. ENVISION is an 8-year global project funded by the U.S. Agency for International Development, or USAID, for the control and elimination of lymphatic filariasis, onchocerciasis, schistosomiasis, 3 soil-transmitted helminths, and trachoma. ENVISION currently works in partnership with national neglected tropical disease control programs in 19 countries. For more information, please check out our website at www.ntdenvision.org or follow us on Twitter at RTI_FightsNTDs. I'll now pass the webinar over to Geordie Woods from Sightsavers, who will provide background on the toolkit.
Good morning, everybody. I am glad that you're all here, virtually at least, and thank you to Kaylee. I'm going to quickly give you a background on how we ended up with the toolkit focused on social mobilization and communication strategies for NTDs. Just sort of a brief assumption of the communication goal for the ENVISION project and across all of the 19 countries that the ENVISION project supports. And it is really focused on increasing adherence to mass drug administration. And the second part of that is to contribute to the sustainability of the entire program. And that's through using a variety of channels and approaches. And so that's a good place for us to start, because this toolkit doesn't just apply to mass drug administration activities. It could be applied to any other types of activities, but we're focused on adherence to mass drug administration activities here. So next slide, please. That looks like so the next, just when we're talking about behavior change and IEC and social mobilization, we call this so many different things, but ultimately, whether you call it IEC, information, education, communication, behavior change communication, social behavior change communication, really ultimately what we want to do is influence the decisions people are making about their health or well-being. And while we're focused on drug adherence, these same principles really apply to more complicated behaviors relevant to NTDs, such as hygiene, stigma of disability, uptake of services such as trichiasis surgery or hydrocele surgery. But again, really, when we're looking at communication, any successful campaign really needs to address. It should tell people that the behavior will improve their health or their behavior. So that's the information part. It should demonstrate or model the behavior, the skills. It should then reduce barriers to the adoption, so problem solving. It should create a system for supporting people who choose to adopt that behavior, so the social support. And then it should provide the materials or resources necessary. So that would be any kind of pieces that they need to adopt that behavior. And then finally, you need to provide a background of support through print, radio, media, or any other approaches, interpersonal. So this is just sort of an adapted version from behavioral economics, but it gives us an overview of where we're coming from. Next slide, please. Again, so again, when we're talking about messaging, it really does matter. And I just take a quick second to read this. If you take ivermectin, you will be less likely to get onchocerciasis, versus relatively the same message. If you don't take ivermectin, you will be more likely to get onchocerciasis. This is sort of an adapted example from a review of Gallagher and Updegraff of 94 studies comparing gain frame, so the first message, versus loss frame messages. And essentially it's saying the same thing, but consequently from that review, people that heard the first message were more likely to adopt the behavior. And this is just, it's of note also that the people who heard the same message were equally as likely to tell you that they would take the drug, but when you looked at the actual behavior, the first one was more effective. And this is a pretty general example, but it's just to highlight the importance of sort of evidence in really using context in the case of building any kind of communication or social mobilization campaign. So, continue on. IEC and social mobilization is how it's framed in the ENVISION project, and that really accounts for a large portion of all of the country's work plans in terms of how they develop and unroll the campaigns that they're working on. But what's less clear, or has been less clear, is how the needs for specific strategies and materials have been determined. And really, it was this was a project that started in 2015, and to really kind of understand where there were opportunities to find efficiencies and maybe even increase cost effectiveness on how we spent or funded these activities. So we went through a number of activities. The first was a cost analysis of budget lines and expenditures across all of the ENVISION projects, and at this point it was 14 countries. And then from there, we coupled that with a more in-depth analysis to see any trends in terms of coverage or successes of failure of the MBA programs. And that was done through an analysis of knowledge, attitudes, and practices data that was available. And then finally, we did a desk review of 4 specific countries, Haiti, Benin, Uganda, and Nepal, to really kind of catalog and review, do some in-depth interviews of what approaches people were using and what materials were available. Based on, and this is sort of based on kind of a diverse set of the different projects. So what did we find out? Across the board, approximately 8% of any country's budget is spent on communication or social mobilization. And this sort of ranged from about 5% to 12%. And what folks were spending the most money on was really print. This budget was largely accounted for by print materials. So, and then kind of going through the in-depth analysis that we did across the case studies, there are a number of key themes that sort of emerged, which became the basis for this toolkit. So the first thing that I mentioned, oops, pardon me. Oh gosh, how can I go back? Excuse me, everybody. I got excited with the clicker. Again, so the first thing that we did is we really took a look at all of the materials and messages across a number of different programs and reviewed the materials for all the materials and strategies and tried to use a number of criteria to objectively review those, so and kind of graded them from very poor to very good. Across the board, I think that what we found that a lot of the materials some were excellent, but a lot of the materials really lacked a call to action, really saying where's the MDA, when to go. There not everything had a clear call to action. And oftentimes, a lot of the materials we found were very technical. We're talking about getting people to participate in MBA activity, and a lot of the materials had a lot of information, very medically oriented, talking about transmission and very, very public health medical information. While that's important information, it may not be exactly in line with the objective of the communication goal. And then finally, I think that any communication material should be attractive, and so I think that we felt across the board some of them could be improved graphically. Another sort of key theme that kind of came out across the board was really oftentimes there was a disconnect between the objectives of the program and the actual messages. This is an example from Nepal, and in Nepal this is results from the survey done in 2015, and the number one reason for people that didn't participate in a mass drug administration campaign or activity was really because of fear of side effects, and this is something that Nepal has struggled with for a number of years. But when we took a look at the messages and materials that Nepal had been using, side effects really were there was very little focus, and almost none of the materials had anything to say about side effects. So again, this sort of highlights the real challenge that the program's having and the reality in the field. The other example I wanted to highlight was just sort of the appropriateness of the choice of materials used by a country. So what we're seeing here in this first bar chart is the sources of awareness for an MD, for a mass drug administration campaign from a specific country. And by large, radio was the clear choice and winner for how people wanted to hear and did hear about the campaign. That said, when we took a look at how much the total expenditure on IEC and social mobilization, almost all of the budget was spent on print material. So, again, there's a bit more analysis that could be done here, but it sort of highlights maybe a disconnect between a missed opportunity in terms of really using the most appropriate channel for communication. And I won't read to you all of these quotes, but this is a number of quotes we found from the different case studies. And one of the other issues that was across the board was really sort of the logistics and distribution and timing. And while folks maybe had a great set of materials and campaigns, a lot of it has to do with timing. If you wait to release the radio campaign for the day of releasing the drugs, folks are not going to be aware. And then, also, there are a lot of other competing health programs out there. NTDs are not the only health program, and so making sure that the timing is really pretty critical. Another big piece that came out was taking a look at how folks are using communication in their role. These programs mostly use community health workers or drug distributors across the board, and communication is an art and a skill, and making sure that those folks are well trained. So you can have the best materials in the world, but if the folks who are delivering the messages don't have the skills to do so, the messages just get lost. So finally, before I stop talking, there's a couple of additional themes that were used. So really, across the board, I think that there was a lack of evaluation of how the materials were used in strategy. So if we don't know how effective our materials are, we can't really talk about it. And the next one is an interesting involvement with headquarters. So for those of you on the webinar that are part of an organization and maybe part of the headquarters, oftentimes there is this tendency, sort of a disconnect between the actual materials and activities on the ground versus sort of what's happening at headquarters. And oftentimes headquarters of organizations approve budgets, similar within ministries of health. Making sure that it's not just a checkbox, but rather it's really a clear strategy. And then finally, there was really a huge variety of different definitions for what we called social mobilization or communication or behavior change. And so it's hard to budget or even plan for if we're not all talking about the same thing. So those were really sort of the key things that came out that sort of built the evidence and was the genesis of why we felt that a toolkit would be helpful. So essentially, this toolkit is designed as an evidence-based social mobilization approach to sort of help walk programs step by step through what it takes to sort of review and analyze a current program and make it better. So with that said, I would like to invite anyone in the audience, the virtual audience, to type in any questions that they've had for me so far. And I'd like to also give a huge thank you to all of the presenters that have agreed to present today and share their experiences. So with that said, I'm going to pass over to our colleagues in Ethiopia who are going to walk us through the toolkit, sort of a step-by-step process, and also provide a bit of examples from what they've done in their countries. So thank you very much, and I will pass over to Leah Wohlgemuth.
Thank you, Geordie. So before we get started into the Ethiopia example, I just wanted to give you all a brief overview of what the toolkit entails. So as you see on the screen, it's a 5-step process, and the first step is the gather phase, and this is the only step that happens prior to the workshop. So this is something you'll need to get together with your team and collect the appropriate documents and materials prior to coming into the workshop, and then everything below the gray bar are the tools and the steps that you go through throughout the workshop. So the first step after you've gathered the materials is the synthesize step. And this is where you fill out a country profile and a message matrix, which discusses all of the things that, the materials that you have and all of the issues and challenges you may have in your country. Following that step, you go into a step we've called align, which is where you look at your challenges and the important aspects you've clarified in your program, and you see how your materials and messages line up. And the last 2 steps are act and verify. The act step is where you develop or adapt any materials you've identified as necessary during the process, and the verify steps gives you a overview of everything you've discussed and actionable next steps, as well as suggested monitoring mechanisms to make sure your materials and messages are reaching the right audience. Next slide, please. So a bit of a background on Ethiopia. We had a 2-day workshop here in August that involved 3 different partners, and we reviewed materials and social mobilization strategies covering ONCO and LFMDA, as well as all aspects of SAFE strategy. So now I'll hand over to Baruch, who will take us through step-by-step of what we did in Ethiopia.
Okay, thank you, Leah. Good afternoon from Ethiopia. In my presentation, I will mainly focus on the steps we have gone through to pilot the IEC and social mobilization in NTD toolkit. I will also briefly talk on the action that we have taken at the end of the piloting process. Before I start my presentation, let me tell you our initial thought about this toolkit. Most of us were not as such interested to pilot this toolkit. Our reason was we thought we may not change much from our current IEC materials that we have been using for the last few years. At the end of my presentation, you will see whether our assumption about the toolkit was right or not. From the 5 steps Leah explained earlier, we went through the gather, synthesize, and align steps during the piloting process. Due to the time shortage, we didn't go through the act and verify steps. We started the pilot process by gathering different information from the ENVISION partners in Ethiopia a few days before the workshop. We gathered information on the knowledge, current IEC material that are being used by the partners, the budget allocated, and the expenses incurred so far for IEC and social materials. And also, we collected some information on relevant research and other pertinent information. Next slide, please. During the synthesis phase, we completed the regional profile for IEC and social mobilization by using the information we have already collected to highlight key information for consideration while developing and reviewing IEC strategies and materials. The initial idea, as stated in the toolkit, was to complete the country profile, but considering the various regional differences, we decided to produce a regional profile instead of country profile. We completed the regional profile for Oromia, Tigray, Benishangul Gumuz, and Gambela regions. Under each regional profile, we summarized and included the information on NTD program focus, objective of program MDA, coverage and delivery platform, budget for IC and the social mobilization, and the 3 key challenges that are considered as barriers to achieve the MD objectives. Next slide, please. In the interest of time, I will not present the whole regional profile of these regions. Just to share with you a few examples from Tigray region, we identified rumors, side effects, importance of MDA at the 3 key challenges that can be addressed by IC and social mobilization approaches. In this region, we have also identified the main trusted source of MDA awareness. The mass media, especially the local radio broadcasting, town criers, community volunteers, healthcare providers, and health stage workers are the trusted source of media awareness in the region. After the regional profile was completed, then we have done a group discussion on several topics, which were followed by presentation and discussion. The first discussion was on the purpose of the IC material, which took much of our time. Next slide, please. As you have probably seen on the toolkit, the different purposes of IC materials were categorized as non-negotiable, those that address the challenge, and also as other categories. As you can see on the left side of the slide, the media awareness, side effects, and disease awareness were categorized as non-negotiable on the toolkit. Next slide, please. However, after the discussion we had on the purpose of the materials, we decided to include the visibility of MDA program as non-negotiable instead of the side effect. This MDA campaign is not visible like measles, polio, and other campaigns in Ethiopia. Next slide. Again, under the synthesize phase, we completed the message matrix where we listed the materials, the audience, and the purpose of the materials. Just to give you one example, we selected the trachoma poster for MDA, and we put community members as the target audience for this material. We also agreed as MDA awareness and disease prevention are the main purpose of this trachoma poster. Next, please. As you can see on the slide, other IC and social mobilization materials and their purpose were also listed in the missing matrix to complete the synthesized system. Next slide. Then we move to the next step, which is the align step. The discussion we had under the align step helped us to visualize and prioritize the existing material that have been listed in the matrix 2 in the previous slide. It also helped us to rearrange the existing material into the alignment matrix, which will be presented in the next slide. Last but not least, the discussion we had under the alignment step also helped us to visualize a representation of what materials are currently addressing the critical areas and the challenges. Next slide, please. Accordingly, in the main matrix, in the line matrix, we listed the purpose of materials, whether the materials are used to address disease awareness, side effects, MDA awareness, and other matters. The purpose were further categorized as non-negotiable, challenge, and other. As I said earlier, we listed the media awareness, visibility, and the disease awareness as non-negotiable, and the side effects and the rumors are the key challenges that need to be addressed through the IC and social mobilization materials. Then we match the materials with their corresponding purpose. Through this process, we learned that some materials have different purpose, and for one purpose, we have also identified different IC materials. Once we have completed the matching, we identified the gap to address the two identified challenges. which are side effects and rumors. Because we didn't have no IC materials that were specifically developed to address these challenges. Before deciding whether we need to keep, adapt, discard, and develop the materials, we assess each materials based on the following criteria. Next slide, please. We have assessed whether our IC materials address the non-negotiable and the challenges, and also whether they reach the right audience. We have reviewed the appropriateness of the message, whether the message is understood clearly, and also whether it was tested. The cost effectiveness and the appropriateness of the delivery mechanism were also discussed in detail. Next slide, please. Here we go. Finally, we agreed to keep only the radio message and the banner, which is used for the motivation purpose. We agreed to adapt all the remaining IC materials that we have been using for the last 2 or 3 years. We also agreed to develop IC materials to address the side effects and the rumors, as I explained earlier. Just to substantiate our final decision, let me say a few points about the IC and social mobilization material that I have in Ethiopia. Most of the materials were not pre-tested on the field. The messages were also too technical. They lack clarity and are open for different interpretation. One thing I also wanted to highlight is most of our IC and social mobilization materials lack geographical appeal, and the message, pictures, and also the delivery mechanisms are kind of one-size-fits-all style. Next slide, please. The brochures you see now on this slide is a good example of this. The message simply lacks clarity and geographical appeal. Now, you can see, as our initial thought about the toolkit was not right after we made this final decision to adapt most of our IC materials and also to develop some new IC materials. So we only decided to keep the 2 IC materials that we are currently using. Then what action did we take at the end? Since we didn't go through the act step of the pilot process to develop and or adapt the materials, we decided to delay the printing of our current IC materials for any day until we adapt or develop the materials as per our final agreement, even though we have budget in our work plan for IC material development. As a result of this pilot process, for our MISION projects here in Ethiopia, IC and social mobilization material developments will not be business as usual anymore. Rather, we are planning to develop appropriate, purposeful, cost-effective, and appealing IC and social materials. Thank you for listening. Leah will take us through the last 2 steps.
Thank you, Baruch. So next slide. So as Baruch mentioned, we didn't get to the last 2 slides of the toolkit, but we did have a lot of conversation during the 2 days, and I'll walk us through the next 2 steps using Ethiopia as an example. So as Baruch mentioned, you see that the ACT step has both a development and an adapt tool. So for the development tool, we decided in Ethiopia we needed to develop a material or a message for both rumors and side effects. Again, these were 2 challenges that we recognized for Tigray region, and they do not have any materials associated with them. So the first thing is to list the challenge or non-negotiable you've decided to develop a material for, and then decide on a message that will address this challenge. So just using side effects as an example, we discussed that we would need to have a list of potential side effects and how to address them. Then you select the target audience for this message, and here we have the community members. Following that, we discussed which channel and material would be most appropriate. As radio is a popular medium here in Ethiopia, we decided that we would develop a radio spot that would address the side effects for MDA. Again, you can see on the next row that we also discussed what we could do for rumors, and one example here is that we decided that perhaps the material wouldn't be a best used in this case, but rather going through community elders to address rumors. So it doesn't mean that every challenge or non-negotiable has to have the material to address it. Next slide. The next part is the adapt tool, and this is where, as you can see and remember in Ethiopia, a lot of our materials needed adapting. So just for an example here, we've listed 3 of the materials that we said needed to be adapted and the desired changes that we wanted to make. So using the brochure as an example, which Baruch showed you, we decided that we needed to change the picture of the woman to look more like someone from that region in which the brochure was being used, and also remove some of the technical information from the brochure, such as that transmission diagram you saw. Another example here is, although they liked the radio PSA was good, there were some changes needed for the radio program. And here we suggested to change the broadcasting schedule so that it was aired before the MDA and more frequently, as well as at times when people would be listening to the radio, so likely in the evenings. And then also add a section in here to also address side effects. So here we can address one of our challenges as well, and then make sure that we pre-test the radio spot. Next slide. So the final step is the verify step, and this is a way to summarize and see a clear snapshot of everything you've discussed during the workshop. So the first step is to list all the materials you intend to keep, develop, or adapt. At this point, you can remove those in which you've decided to discard. And then you identify the delivery mechanism for each item. I know Geordie briefly talked on this, but a lot of times the materials may be okay, but they're delivered at the same time as the drug, or the radio spot is not being played at times when people are listening. So also thinking kind of beyond the hard material, but in which way they are being delivered. Then you should discuss as a group and agree on proposed next steps that would allow for the creation and finalization of these materials or outputs. And then we've added a step to look at proposed monitoring mechanisms. So this is just another way to ensure that the messages and materials are reaching the intended audience and having the impact that you would like. Next slide. So here's just an example from the toolkit. As I mentioned, we didn't get to this step, but you can see on the left-hand side, you still have your purpose, again, labeled by non-negotiable, challenge, and other, and then you have the material, the delivery mechanism, any proposed next steps you've agreed upon, and a monitoring mechanism which you can use to monitor. So that takes us through all of the steps for the toolkit, and now Scott will explain next steps for Ethiopia as well as the lessons learned from the pilot.
Thanks, Leah. So I'm going to, for this part, fill in for Baruch Kabede from the FMOH. He's asked me to fill in. He's running a bit behind. So having done this pilot, the FMOH found it to be a really useful tool. They were impressed by the conversations that came out of it, and so they want to take it to a next step, and that would be a national IEC BCC standardization workshop. So essentially, you would take all the NTDs and all the partners that are involved in NTDs and standardize messages and materials. Now, this would be for general standardization that would be mutually agreed upon, but it's also important to note that it would still allow for a tailored approach specific to the language and culture and MDA challenges that might be inherent to a specific area. Once that messaging is standardized, it can then be integrated into the National Integrated NTD Refresher Training Initiative that's currently being rolled out, so that we'd actually be sure that well in advance of MDA, health extension workers and other cadres of health workers would be well aware of the materials and how to use them appropriately. And then, along with this workshop, we would also identify mechanisms for monitoring IEC materials and social mobilization. Right now, some partners include questions within their coverage surveys. things like that. Maybe during pre-MDA census, they ask how much, they include questions there. But this would just be a way to standardize this across the country so that when you meet in subsequent years, you'd be able to evaluate the materials again before MDA and tweak things and make changes. So, for example, for ENVISION, we have put a hold on all of our IEC materials until this national standardization workshop so that we're able to incorporate all of these findings. So really helpful steps in just developing truly productive materials. Slide. So I'm just going to provide some lessons learned from what we noticed about the pilot. All in all, I think it was very well received and appreciated by the partners. It provided an excellent tool for starting a dialogue about the goals of IEC BCC materials. You know, often you see a tool and you can see that in some way it's not what you need it to be, but it's very hard to quantify that. So this really provides that step-by-step process. And perhaps more importantly, it also provided a dialogue for what you're trying to achieve with social mobilization. You know, when we went through our non-negotiables, almost everyone thought putting the full SAFE strategy on every single poster was a non-negotiable, because that's good public health. But it's not necessarily good BCC practice in terms of social mobilization. It depends on what you're trying to achieve. And so there was a real sea change in thought as the workshop progressed. And I think that in and of itself makes the tool really valuable. You know, we did have several different regions, Tigray, Oromia, Benishangul, Gambela. Those are all different cultures, they're different languages, but still there were a lot of sort of common themes that came throughout. So I do think there's a lot of advantage to bringing different regions together to find those common themes and find ways to address them. Just a few things on logistics. Definitely keep the workshop small. No more than 10 people. This is not meant to be one of those enormous workshops. It really benefits from that in-depth discussion. So it's going to be crucial that partners assign the appropriate people to attend these workshops. That's not necessarily going to be the program manager. A technical advisor might not be the person that you want to send if you have someone like a communications expert that could be there in the advisor's stead. It took us 2 days to complete just 2 steps of the tool. We took it a bit farther. We looked at all of the SAFE materials that our partners had developed, as well as OV, LF, MDA. But if you were just going to focus on one specific MDA social mobilization strategy, definitely you would need 2 days to implement that. And then, you know, you can really easily adapt this for use in other areas, TT surgery, LF morbidity, WASH, any kind of materials like that. I think it would have a lot of purpose. The FMOH even made comments that this could be useful for other health topics, malaria or tuberculosis. So really a good tool across all of the public health areas. Okay, next slide. Oh, now I'll be handing this over, I believe, to who's up next?
I will introduce our next. This is Geordie again. Thank you, Scott, Leah, and Baruch for that example. I think it really is. It's interesting to sort of go from the design of the tool into actually using it. So I also wanted to introduce Benjamin Benagwa, who is the resident program advisor for RTI International in Uganda. And they also took this tool and adapted it to Uganda's purposes, and I wanted to just let Ben introduce himself and talk about what they did in Uganda. So, Ben, I will hand over to you.
Thank you very much. Hi, and good morning to the team. Can you hear me?
Yes, we can hear you. Thanks, Ben.
Great. Hi, and hi to everyone. We are glad that this tool came in when we the ministry and ourselves were preparing to finalize the social mobilization strategy that had been on the shelves for the last 2 or 3 years. It wasn't being used at all. So we are lucky that this tool came in at a time when we are moving towards finalizing this strategy. So in effect, we didn't have a clear strategy for social mobilization for MDA or NTDs in the country. And whatever was being done and the materials that had been produced were really not based on any process that was in place to guide this development of the materials and approaches that were being used. So we are glad that this came in when we are doing that. So we had a 3-day workshop that had participants from the district level and the national level, the program managers, and both technical in
Hi, Ben, it seems that the phone might have dropped over there. Ben, are you still there with us? Okay, let's take just a second. Ben, if you can redial back in, we'll just take a couple questions right now from the audience and see if we're able to get your phone back on. We had one question from Evidence Action from the Delhi office. The question is, I think this is for Geordie. Do we have any experience on effectiveness of digital platforms such as SMS, IVR, mobile apps, etc., for social mobilization?
Thanks. I think there are a number of examples of using that. In the ENVISION program specifically, I don't believe we do, but there are a number of examples. I can think of the Trachoma programs, for example, and in Zambia, one of the things that they're doing is they're actually using SMS to speak to not only drug distributors but also community wash organizations or community wash groups. So there are groups based at the community level that get together and discuss the water and sanitation issues. And so before MDA activities in Zambia, they receive 2 or 3 SMSs reminding them that the MDAs are coming up. And there's limited evidence around that, but I will say that they have had extremely good coverage of over 80 and up to 90% coverage rates. So I think that that's certainly a positive example, and we would love to hear from others about other platforms like that. So, but yes, I think that there more and more there are examples of using social media for social mobilization. Are there any other questions, Kaylee?
Yeah, one of the other questions that someone shared earlier was, how can monitoring of social mobilization demonstrate successful behavior change? And Geordie, just before you start answering that, I wanted to just take a second. Anyone on the line, please go ahead and share your questions. If you look at the right of your screen in that GoToMeeting toolbar, if you look under questions, you should be able to type those in, and we'll share those with the panelists. So please type in your questions now. And hi, Ben, is that you?
Yes, that's me.
Okay, great. Good timing, Ben. You're back on.
Yes, I am.
Sure. Do you want to continue?
Let me just finish, just to quickly say that the workshop provided an opportunity to look at the gaps and what the materials we had were addressing vis-a-vis the issues that had been raised in the reports, field reports, and MDA reports based on our treatment data that we had. So we were able to classify the materials to look at whether the materials were actually addressing the key issues and making sure that the strategies aligned with what the existing challenges were in terms of improving our treatment coverage. So some of the key issues that had been identified are fear of side effects from some of the drugs like PZQ, praziquantel, and also fear from, we've had sensitive gender issues where some men believe that if their wives took these medications, they would render them infertile. So the process helped us to align these steps and make sure that the materials that are not addressing critical issues are put on the side, and look at which gaps in terms of materials we need to fill in order for us to address these issues that had been identified in the reports and field supervision documents that we had. Of note, really, from the alignment step, it was to identify other strategies outside of the printed materials that would address the real issues, because a lot of what had been happening was a focus on print materials to address mostly the technical issues in the program, and which we thought were not necessarily addressing the issues. So the workshop using the tool helped us to align our issues with the materials that we had and make sure that we have a plan for developing some new materials that were not available to address some of the issues that we are dealing with. We also identified that some of the channels that were being used were not in sync with the demographics and the location of our communities, and therefore, in our discussions during the workshop, we identified that interpersonal approaches to supporting IEC and behavior change would be more critical than just sending materials out there, because some of our communities are not even able to read and leave alone interpreting what is on the materials. And in terms of verification, we're based on the strategies that we designed. We designed a clear log frame to clearly look at the activities that we need to implement as part of our social mobilization activities, clarify the outputs, and look at the outcomes, and eventually look at what type of impact we would get in terms of IEC and social mobilization by using the different approaches and materials that would be put in place. So we developed a logical framework that addresses the different elements based on the activities that are going to be implemented in line with the tool that we were using to guide what we were discussing and coming up with. So we really found this as a very useful tool. It helped us, the participants, to then be able to approach IEC and social mobilization in a systematic way, but also provide an opportunity for a systematic review of the IEC materials based on the issues that had been identified during the gather stage of this tool. So this has been a very useful tool for us, and we hope that what we've come up with, having used this tool, the Uganda strategy for IEC and social mobilization is now very clearly defined based on the critical issues that need to be addressed and identifying the right type of materials that need to be put in place, but also considering the different channels that would be useful to reach the target audiences that have been identified based on the analysis of the issues that we are dealing with. So thank you very much.
Thank you, Ben. Again, thank you to all the presenters. And yeah, just sort of coming back to what both I think Ben and Scott highlighted, this review and analysis of communication materials is not a new process, but I think that what we've really tried to provide with this set of tools is a space to create a dialogue and a very clear process to go through that dialogue using this set of tools. Yeah, I really encourage folks to download it, use it, and provide us feedback where possible. That said, I'd like to open the panel back up for any questions for any of our presenters, and I'll pass on to Kaylee to sort of guide us through that process.
Sure, thanks, Geordie. Let's go back to that one question that we were talking about before Ben rejoined us, which was how can monitoring of social mobilization demonstrate successful behavior change? So
I think, again, a part of, the first important part of that question is making sure that you are monitoring the activities that you're doing in terms of communication or behavior change. So it comes back to the example in Uganda of systematically having a log frame and beside each activity, making sure that you know what you're measuring. And that can come in a number of different forms, anywhere from routine monitoring, such as these field reports that Ben had mentioned that are so critical to understand really what the issues in the field are, any planned coverage surveys, planned impact surveys, and other things that I think that folks have used less, like when people do radio campaigns, there are ways to use other folks' data, like omnibus surveys. So really making sure that you document, and so documentation is really the only way that you can talk about any kind of impact or success of your program. So ultimately, when we're talking about mass drug administration campaigns, your success will come in the form of having a good coverage rate. Now, with other behaviors, it would be a different outcome. But I think that it's really about systematically making sure that you are measuring the activities that you're doing. Great,
thank you, Geordie. We had another question come in. This one's from Lucia Nadaf from Orbis in Zambia. She was saying how the Zambian experience is that posters have been more effective. And then she had a question for the Ethiopian panelists, asking how effective have brochures been in their experience, considering that people have to take the time to read through the brochures. If you can speak a little more about the effectiveness of brochures there in Ethiopia. Nope. Leah, there, go ahead. You're unmuted.
Okay, thank you. In fact, we didn't do the surveys like to come up with one of the IC materials that we have is more effective. But based on the post-MDA coverage survey, we have done certain regions. Most trusted and common source for MDA information for the community members is radio and the town criers. Brochures are mostly posted at the health center level where the community may not have access. And they have also a lot of text and unclean pictures. So as a way forward, we are planning to have a poster with a clear message, short message, and a clear picture so that people can easily understand. But so far, we don't say that poster is more effective than local radios and other social mobilization materials.
Yeah, if I can just briefly add to that, I think one of the things that we found here is that there was sort of a very set belief that flyers, posters, and brochures are the mighty trinity, and you have to have all three of those, and once you have them, you've achieved social mobilization. And so what this practice enabled us to do is really look at which one of those, or if any of those, are effective in terms of reaching the community. If you did nothing at all, would you really see that difference in terms of your final coverage? So really having that conversation, I think, just it enables you to break long held beliefs about what works and what doesn't.
Great. Thank you, Scott and Baruch, for the responses there. We have another question. This one is, could you please talk a little bit about how you plan to address the myths and misconceptions and rumors without using IEC materials in Ethiopia? And I remember, I think, Leah, you had said something about, materials are not always necessary. You had some community leaders do that. If you want to take that one.
Yeah, in order to address especially rumors, we are trying to use the local leaders and the community leaders, the religious leaders, to address this kind of rumors. By doing that, actually we are effective in most of the regions. That's what we are doing and keep doing.
Okay, great. Thank you. And we keep getting more and more questions. I'll keep going with them. We have time to take a few more. So, Scott, did you want to add something on that last question?
Just to say that this came from, this was tested by FHF and Oromia, where they had some trouble with coverage due to some distrust in the communities. And rather than use materials, they gathered all the elders of these specific sub-districts and held workshops with them so that they could go back and be agents of change. So that's kind of where that's coming from, as a practice that was used in our last fiscal year and did result in better coverage this fiscal year.
Great, thank you. And this is another question that could be either for Uganda or Ethiopia. How did workshop leaders present the whole idea of the workshop to their initially skeptical participants? How did you persuade them to open up their minds and go through the exercise of the workshop?
Can you come again?
Sure, Ben. The question was kind of how did you kind of convince leaders to have the workshop for the social mobilization? Did you have to persuade people to hold the workshop in the first place?
Okay. I think Uganda had we had the task of putting in place our IEC or social mobilization strategy, a strategy that had been on the shelves for quite some time. It hadn't been finalized, and certainly the ministry, ourselves, and the program managers really thought that given the existing data we are getting from our treatment coverages, there was a gap in terms of the extent to which communities were being mobilized to turn up for MDA activities. And therefore, there was that need expressed and felt that there is need for us to have a social mobilization strategy in place. So it wasn't really difficult to get the program managers, district people, and program officers supporting NTD programs in this country to come for this 3-day workshop. So it was already a need that we have to have this workshop as a team. And then one thing that made it even more interesting is the systematic approach using the tool that we have. I think it was something new to those who are not necessarily IEC people, to see that there is a systematic way that can be used to put in place a strategy or strategies to address areas or issues that are affecting the program. So it was, in Uganda, the workshop was really taken with a lot of interest, and I think the team is looking out for the product. And when we went through the materials that we have, there was very clear evidence that some of the materials we had are not at all relevant to the issues that are being expressed at the community level. And this continued to help the team to get more interested in the workshop and the interaction that we had.
Great, thanks very much, Ben. Ethiopia, would you like to add?
Sure. One thing that we experienced here in Ethiopia was that originally the Federal Ministry of Health was planning to go on and do a separate workshop, and after seeing the results of this toolkit and how it actually happened, they are now planning to roll out a similar workshop in the national IEC BCC workshop that Scott mentioned. So I think oftentimes when people hear toolkit or topics around IEC and social mobilization that can tend to be unclear, just having practical experience and being able to explain to any leaders or advisors that this has been done in countries and it's worked well and had positive results can be a good way to kind of persuade them.
All right, great, thank you. Unfortunately, we've run out of time for more questions, but we will answer your other questions that you've sent in by sending out an email to everyone after the after this webinar today. And we've reached the end of our time here, so thank you all for joining today. We will also be sending out the slides and a recording of the webinar and the toolkit itself, and it will also be made available on the ENVISION website at www.ntdenvision.org. You can also find recordings of our previous webinars there as well. And we just want to ask you if you can all take a second to complete the evaluation. It's very brief. The link is here in the chat box, and we'll also email it out to you after the webinar again. And with that, we'll close the session. Thank you all so much to our panelists today and for all of you who are joining us today. Have a great day. Thanks. Bye-bye.
Thank you. Bye-bye.